Thank you everyone for joining us today for the Arnhold Institute's continuing webinar series on what must we do now. I'm especially excited today for our topic on decolonizing global health education. And we are very excited to have today with us Dr. Christian Montenegro, who I'll introduce in just a moment. For those of you in the audience, if you have any questions that come up during this discussion, please put them in the Q&A box. We'll be keeping an eye on that, and we'll have an opportunity to have a question and answer time at the end of our discussion today. So just by way of introduction, my name is Diona Lee. I am a pediatrician by training. I came to Mount Sinai in 2018 as a pediatric hospitalist at Kravish Children's Hospital. And last July, I was appointed to be the Director of Global Health Education for the Arnhold Institute for Global Health and our Department of Global Health and Health System Design. In this role, I lead and expand bilateral educational opportunities within the Arnhold Institute strategic partnerships in Ghana, Kenya, Nepal, and New York. I also partner with departments and programs across Mount Sinai to ensure the success of global health education initiatives and programs. Additionally, I serve as the Global Health Track Advisor for the Masters in Public Health program at Mount Sinai, mentoring and supporting students in the track and engaging in global health opportunities. And aligned with the Arnhold Institute strategic goals, I support efforts to promote justice and equity in our global health education programs and partnerships, and work towards advancing our larger goal of decolonizing global health. Our esteemed guest today is Dr. Christian Montenegro. He is a qualitative health researcher with a background in sociology, community psychology, and public health. His work concentrates on the set of exchanges between health and democracy at the micro level, including service user experiences, participation and engagement, and at the macro level, which includes democratic transitions, human rights advocacy, and social movements. And he has a specific focus on mental health and psychiatry. He has conducted research on the experiences of caregivers of persons with psychosocial disabilities and their interaction with care providers, the activist practices of mental health service users and survivors, the political and administrative dimensions of community participation in healthcare policy, and the social and cultural aspects of early intervention in psychosis. Currently, he's a research fellow at the Wellcome Center for Cultures and Environments of Health at the University of Exeter. And he's also a researcher at the School of Nursing at Pontificia Universidad Católica de Chile. At the center, he is starting a new line of research around medicine and urban protest, looking at the informal actions of medics, nurses, psychologists, and psychiatrists giving care to wounded protesters outside and sometimes against the state. He's a founding member of the Platform for Social Research in Mental Health in Latin America, an editorial board member of Critical Public Health plus Global Public Health, and part of Somatosphere's editorial collaborative. It's my great honor to welcome you here today, Dr. Montenegro.
Thank you, Diana. It's a pleasure to be here.
We decided to talk about this topic of decolonizing global health. We know that global health developed out of colonial systems and in many ways mirrors or replicates those power structures and dynamics. And so we want to focus today primarily on how we can work towards decolonizing or reinventing these dynamics within the realm of global health education specifically. And I know this is a topic that you have both spoken on and written about in the past. And so we're very excited to learn from you today. Just as a way of background, for the Arnhold Institute, we focus on building long-lasting equitable partnerships based on the ANPATH model, or the academic model for providing access to healthcare. And in our educational efforts, we're really trying to build programs that are mutually beneficial, which includes incorporating bilateral educational exchanges, but also is starting to explore questions about whose opinion and whose experience is valued, and how we include sort of all the voices of our partners involved. We, as I mentioned, have 4 partnerships in Kenya as part of the AMPATH Consortium, in Ghana with the Navrongo Health Research Center, in Nepal with Zulikal Teaching Hospital and Kathmandu University School of Medical Sciences, and here in Queens, New York with Elmhurst and Queens Hospitals, and some community-based organizations. So we're eager to learn from you on how we can continue to be introspective and look to improve how we build our partnerships. So I wanted to start off today. I think, you know, the entrenchment of colonialism in global health is evidenced even in the language and the terms that we use to speak about it. Terms like the field or site or the global north or global south all have roots in colonialism. And so I was just wondering if you had some recommendations for today and how we approach our discussion and what sort of language we should be using as we discuss this topic.
Yes, well, I think that, yeah, as you say, lots of concepts are problematic because they are originated in a certain matrix, a certain way of kind of partitioning the world. But at the same time, we need concepts to communicate and actually to talk. So I think that as long as there's a chance to unpack those concepts a little bit, then it's fine if we use them. As long as it's in a context of a conversation, I think it's okay.
Okay, wonderful. And I do ask, you know, if there are any terms or ways that I'm saying things that you think could be done differently or better, please feel free to give me that feedback as we talk today. So also, before we delve into decolonization, I also just wanted to take a moment to talk about the importance of global health education. I know for myself, my experience in global health was ethically complex, and I struggled a lot with some of the dynamics that I saw, but it also made me a better physician and really inspired me to want to become a clinician educator who created opportunities that were equitable and transformational for learners around the world. So I guess from your standpoint, what does global health education mean to you, and why should we value it as global citizens?
I think that just as you have your kind of a specific history in how you approach this field and how you got to become who you are in the field, the same for me, and I think the same for everyone. Like we get into this discussion and this field via different paths, and I think those paths are important in a way because they define how we feel in this field of global health. So in my case, I would say that my reflections around this started when I was doing my PhD. I come originally from Chile. I studied sociology there, and then I moved into the UK to do a PhD. I was working with data from Chile. I was working with problems that were problems in Chile, but I was trying to convey that and to write about that for a British audience or an European audience. And I think that this kind of a double positioning of being from one place and trying to make yourself understood by a different audience is what started kind of my own reflexivity around this. Because I thought that, because it was funny, because my research was seen as global health research, but in Chile, in my own country, my research was just public health, was kind of or community health. So this duality was interesting for me. I was classified as global health just because I was in London doing research on a faraway country, you know. And then I started realizing that this was the case for a lot of other research. So depending on where you were and who your audience was, what you do counted in different ways. And actually, what I wrote about this, my first piece around this topic is an outcome of that. Now, in terms of why it's valuable, I think that this process, even if it's complex, is extremely valuable. The moving ideas from one place to the other, trying to make sense of ideas from one context to the other, I think is extremely important.
Thank you. And it's really helpful kind of to hear everyone's different experiences. And I think it is part of how we sort of learn from each other and learn sort of the diaspora of experiences that exist, and how we can learn from each other. For those of us who are joining today who might be less familiar with the movement to decolonize global health, do you think you could briefly summarize some of the recent discussion around the topic and sort of the major issues that have been brought up?
Sure. So I would say that fundamentally the movement for decolonizing global health calls for the recognition of the colonial legacies of the global health enterprise in a way, and the lasting legacies. That means recognizing that global health is the latest iteration of a chain going from colonial medicine to tropical medicine to international health and then global health. And that recognizing this history or this historical connections, it matters in a way because they are still present. So I would say that there are three main aspects to this. So first is a reaction to the lack of diversity and the asymmetries in the very field of global health. And these asymmetries and lack of diversity is exemplified, for example, by where journals are located, where funding is located, who the editors of the main journals are, where the global health programs are. So kind of a first reaction is a reaction towards this lack of equity in the distribution not only of resources, but in the distribution of voice, of who is leading or who is shaping the field. And then you have a reaction that is based on this notion of positionality, which is an interesting and important notion. It means how we see ourselves as researchers and who we represent. Because in a traditional modernist paradigm, global health research is empirical research, so it doesn't matter who you are. It matters what you are looking at, what are you observing, like your object, your empirical object. But in the decolonizing movement is also a call for the recognition of positionality of who you are. And this has a lot to do with feminism. I think it inherits this conceptual aspect from feminism. And basically this means that what I was saying at the beginning, if you are writing for an international audience, and if you come from a very specific country, you deal with these issues. It's not indifferent who you are and where you come from. It's not indifferent for the kind of output that you create and the kind of messages that you create. So this is a second aspect. And finally, I think there is maybe kind of a deeper critique of the epistemological foundations of global health and health research in general, because it is basically the main sources of knowledge around health come from kind of an Anglo-Saxon European context. And this includes certain conceptions of human being, certain conceptions of the body, certain conceptions of pain, that are not shared everywhere in the world. So there is a recognition that there are different worldviews, and those worldviews include conceptions and traditions around health and well-being. So I think that these three things, like the asymmetries in resources, the asymmetries in recognition, the positionality, and the epistemological critique are key aspects of this movement.
Thank you. That was a great summary. I've been doing a lot of reading on this topic, and I think you pulled that together in a very understandable and great way. Even as I'm trying to piece together all the things that I've been reading. So I guess sort of related to the last question, are there global events that you think have really influenced and contributed to the recent prominence of the decolonizing global health movement, and what are some of those?
Yeah, I think that there is a very interesting confluence of processes, I would say. Processes that are material, and also I would say like normative and even ethical process, like an ethical sensitivity to injustice and see, at the moment, I'm investigating medics and nurses' reactions to police violence. And you can see that this is something that also has been growing a lot, like a growing concern around police violence, state violence. And kind of it seems that the health field is more open to engage in a kind of a more serious critical discussion around these topics than I don't know 20 years ago. There is a heightened sensitivity now because of my own experience. I think it's important also to recognize some material drivers of this. For example, in Chile around 2006, there was a huge investment on sending Chilean students to do programs abroad. This was because copper, which is the main export in the country, the prices of copper grew. So the president at the moment decided to use a lot of this excess in paying for international programs for Chilean students. So I benefited from that. And if you look at China, Colombia, or Malaysia, and many other countries, Indonesia, those are nations that have made strong investments in sending students abroad, including students that will go and do global health programs. And if you work in a global health program in the global north, you will notice that you have a lot of international students, and sometimes you have students from specific countries that seems to be investing a lot on this. And I think that this army of kind of a fresh minds coming from one country to another and trying to understand this difference, I think is key to understand the force behind the decolonizing global health, because actually a very important player in this discussion are student groups in global health programs in international institutions like in Sweden or in the USA, in Canada, in the UK. I can see this because I've been invited to by those groups several times. It's students that are concerned, and some of those students are precisely international students that are based in these institutions and are trying to, in a way, shape those institutions from their southern knowledge, to put it in a way. So I think this is an important aspect of it as well.
Yeah, I mean, I have seen too the students here really be a force for pushing some of these issues, and so it's one of the great parts of being in education is also to be interacting with these students and their just their passion and their coming in with new ideas and so I guess again. In thinking about some of the things that you've written about and spoken about previously, I guess what do you think it should look like to teach global health from the so-called global South? Again, not living the term, but thinking about what does it look like, or what should it look like to teach global health?
This is something that with colleagues in Chile we thought a lot about, because one of the papers that I think was shared with this invitation it's called Teaching Global Health from the South, and it was out of a practical need, because we thought there was a need to include global health modules within the nursing school, which I was working at the moment, and but at the same time we thought, okay, how is this different from public health, and at the same time, like, why shouldn't we just teach public health instead of global health? Why is it necessary in a place like Chile, who has, as many other places, so many kind of local needs and local challenges in terms of public health? And I think that was a key question for us, because it was also the question of many colleagues, like why would you create a global health program in a place where you have so many public health needs? And I think that our answer to that, or my answer to that, was that Chile, as any other country, is already shaped by global forces. And even the kind of health that a country can provide and the kind of investment that a country can put into health is kind of determined by global economical forces and global economical pressures. And so even for your local plans, you need to have a good knowledge of global dynamics. And at the same time, our answer was, we should also be able to share what we do locally to a global audience. And if we are only focusing on our local needs and local solution to our local needs, then we will never develop this ability to share our innovation and to frame what we do as a globally relevant innovation, which I think is also something very important. Now, if we move this conversation to the north, to the so-called north, I think it's key for global north institutions to actually recognize the innovations that are happening in an international kind of a frame and in many different countries. I don't think that we have all the innovations or that everything that is valuable exclusively comes from the South. I think that is not the case, but sometimes the possibility of innovations coming from the South is kind of erased in advance in many discussions, and low and middle income countries are seen as only in need of the technical and the technical assistance or the resources coming from the USA or the UK. I think that if we could recognize that innovation is happening in a more distributed way across the world, that is already kind of a change.
Great, thank you. And, even though we're kind of now talking about location and, the so-called global South and global North, I've also heard you share previously the ways in which the COVID-19 pandemic and the virtual environment, which we're actually on currently, that so many of us operate in now, has in some ways collapsed the importance of where someone might be quote unquote based. So can you explain a little bit more about your thoughts on that, and perhaps how the pandemic has created both new challenges, but also new opportunities for global health education and decolonizing global health education?
Yeah, I think, I think what we are just starting, and maybe not even yet, we don't really know what the pandemic actually means in terms of our societies and our lives. We are just seeing the many effects of this, and of course we all know that the main impact has been on our health, and not only our physical health, also our mental health, especially of kids and young people. So this is an issue, and we will have to deal with it for decades. But at the same time, I do think that the need to move into a virtual environment has meant that we have extraordinary conditions to engage in more diverse conversations, I think, to put people together, to recognize what I was saying before, to recognize the existence of local traditions. A local tradition doesn't necessarily mean ignorance. I think this is very important. A local tradition also means different ways of solving issues. When resources are scarce, or when you don't have all the technical mechanisms. So being able to listen to that, being able to understand that, I think is important. And this move into a virtual environment creates better conditions to do that. Now, it's always important also to recognize that the internet and the ability to use it is not necessarily universal, and in many places this is still a necessity. But if we compare the situation, I don't know, 5 years ago, and how hard it was to put up a panel with people from different places, and how expensive that was. Now it's like we don't even think about like planes and food and catering. We think, okay, we know this person here, so why don't we try? And the same as you do with me, I do with other people. You know, we are all kind of taking advantage of this. So I think it's important.
Yes, I mean, I think even our ability to have you join us today was facilitated by the fact that
Absolutely.
we're able to do this virtually.
Mm-hmm.
Another thing that you've written about and talked about previously is the impact of English and it being sort of the dominant language within the global health arena, especially in the academic global health arena, and the predominance of the biomedical approach and the impact that that has had. And we can see that, you know, the predominance of English can severely restrict those who are allowed to participate both globally, but also within countries, as the privileged are often the ones who are given training in speaking and writing in English. So can you also kind of speak to this a little bit more, both about English as the predominant language, but also the biomedical approach being predominant and how that has impacted the dynamics in global health education and academics as well?
Yeah, I think that, I think there are some aspects of global health that, in a way, that we need to consider. For example, global health has a tendency. Health in general has a very practical orientation, which is natural, you know, because it responds to a need. And when you have a need in front of you, when you have someone requiring urgently a service or an intervention, that kind of organize the whole system around that need. So there is an imperative of action, which I think it needs to be respected and needs to be considered. But the thing is that because of that imperative, sometimes we don't take time to engage in things that could allow you to better understand those contexts. For example, translation. Translation is something that seems kind of antiquated. It's hard. It's like an art. It requires time. It requires planning things in a different way to make yourself understood to a public or to a patient that doesn't understand your language. So I think that we need to bring translation back into this, because we need translation if we want to recognize the diversity that I was talking about. You know, if we recognize that across the world for hundreds of years, communities have dealt with disease in very different ways, and if we recognize that there are many different traditions around how you deal with illness, then the next logical step is to translate those traditions and to engage in the effort of, for example, translating classic work in social medicine in Latin America. This is something that's been done recently, and Latin American authors are invited to translate their work in English so that this is widely known. I think that's a very important thing to do. And I think that journals should be more mindful of this. I think that, I'm talking in English at the moment. I trained at the LSE. So there's no way I can say, okay, we should avoid English. I think that English has allowed me to read about what's going on in Palestine, to drop an email to somebody in Japan, to consolidate a certain network with people in I don't know, in Russia. No, English is not only beneficial for the people that is located in English-speaking countries. You know, it's also beneficial for everybody else, in the sense that it allows you to connect and to understand realities beyond the English-speaking world. So I think this is also something that we need to take into consideration. But more investment and more time is required to create translation of work, translation of speech. I think this is something that we need to look into. And for a journal to make work available in more than one language is a very complex task. You know, it requires kind of a whole reshuffle of how a journal works. But I think we need to consider those, we need to be ambitious about this. And in the context of teaching, inviting a non-English speaking teacher and having a good translator there to interact with the students could also be something we need to invest more in.
Yes, I think those are all very important. And I echo sort of the level of resources that would be needed, but we need to commit to that, I think, to actually really try and push some of this change. You know, at the Arnholz Institute, we like to invest in reciprocal innovation and the idea of sort of disseminating evidence-based care models and best practices to any context where it might be available to improve people's health. But as you said, it's very challenging to sort of source and adapt relevant global health solutions to different contexts. So do you have thoughts on sort of best practices and how to share knowledge across contexts that both have perhaps different languages, but also different cultural understandings, different approaches to disease and all of these things, and how to best engage with collaborators around this?
Yeah, yeah, definitely. I mean, in one of the pieces that I wrote in last year with Francisco Ortega, it's a piece on global mental health and cultural contexts. And one of the things we argue there is that in a way, we always, I mean, most of the time when we think about a health intervention, the way that it works is that an intervention is defined and designed in a place like the USA, for example, and then it is applied in another context. That's usually the directionality of the process. So we see culture as something kind of as a barrier that we need to overcome in order for our intervention to make sense and to be successful. So this can naturally be the case. This is sometimes the case, and it's okay. And you actually need to overcome barriers, but culture is not just a barrier in a sense. That's kind of what we argue there. Context is something that is always shaping things, it's always moving. It also represents a potential of learning for you as a USA-based physician or global health scientist or teacher. You know? So we always should try to see this not in terms of how to overcome a limitation, but more in terms of how to engage in a conversation, I would say, how to engage in a dialogue between what I've been doing with my institute or with my colleagues, what we see as appropriate and as successful and effective in terms of health intervention, and what you do and how you see it with your colleagues and within your situation. Sometimes we frame culture as kind of this closed kind of a bubble that is very hard, is very weird, it's like entering another world. And to a certain extent, it could be like that in some aspects. But I think at this time and historically, biomedicine is so well spread across the world that there are certain languages that will always be shared. You know, there's always a medical community in every country in the world that already has a certain shared language. So it's very important to see that there's always potential of conversation more than overcoming barriers. I think that's an important kind of a change of framing that could be implemented.
Yeah, and it's interesting, as you described, that sometimes culture is placed in this bubble, and I kind of connecting some of your other thoughts, I think, our focus on the biomedical perspective is perhaps what pushed it into that bubble. But as you said, it's also an opportunity to, if we are ready to have this conversation and to explore it, to really have a bigger impact on people's well-being and overall health. So yes. And then kind of knowing your expertise in global mental health, do you have thoughts on global mental health education, how that might be evolving and expanding within global health realm? As you mentioned, with the pandemic, we're seeing such a huge impact on mental health.
Yeah.
And as a pediatrician, I definitely see it amongst especially our adolescents. So it'd be interesting to sort of hear your thoughts on how global mental health and global mental health education could move forward in this setting.
Yeah, I think that the discussion usually people that works in mental health, as I do, we always think that we work in a kind of a very special field, because there are some reasons why it's kind of unique. It's kind of different to health in general, in the sense that people's subjectivities are much more involved in how they experience a mental illness, in how they describe what they are feeling, in how they are given a diagnosis. This process is much kind of strongly subjected to cultural diversity and to cultural specificity. Even what sadness means, when sadness becomes disabilitating, what does it mean to hear voices and to act on the basis of those voices that you're hearing, you know? What does it mean to be medicated with a strong drug that will maybe be good for you not to listen to those voices anymore, but at the same time won't allow you to participate in productive labor with your family, you know? And how those decisions kind of have a different impact and a meaning in different contexts. So those are kind of the questions that we are always asking in the global mental health field, and particularly when we are looking at cultural aspects. So I think that, all of the things that we've been talking can be applied also to this field, in the sense that recognition of local specificity, recognition of what we call local idioms of distress, how people talk about their distress is critical, particularly if we want to scale up services, because we know that mental health has been traditionally given low priority by governments, and that means low priority in terms of funding, low priority in terms of the research that is conducted, low priority in terms of services available and investment. And this is something that we kind of all agree on, that mental health requires more investment and more priority. But every time you think about how to scale up things, how to grow in terms of services availability, then you will have to face those questions, like how do people actually receive care from? Because it's very different to go to a GP or to primary healthcare because you have a toothache, than because your son is acting bizarrely or weirdly or in a way that is different from what he usually is. There are issues of shame. There are issues of what you expect a doctor to do about that are very different in different places. So I think that my answer is that in global mental health, all of the things that we've been talking are particularly acute and particularly important. That's kind of my approach.
And then sort of as we're closing out our discussion time, and we'll shortly open it up to questions from the audience, I guess, in thinking about all the things we've discussed, what are some of the priorities for decolonizing global health education from your perspective?
I've been thinking a lot about this, and I'm actually at the moment writing a little project around this to see if I'm successful, because I think that, what you literally need is better means of communication. So traditionally, the means of communication for global health and for health have been journals, you know, and we rely a lot on the idea of the journal. We expect maybe too much from what a journal can do. So we are always pushing journals to diversify the editorial committees, to be more open to other languages, to be more open to different kinds of formats, including poetry, including art, and that is fine. I think that is a nice evolution. But at the same time, we need to think of other media, like other forms of communication. For example, now we have podcasts. We have the ability to have these conversations that we are holding right now. And these kinds of things they do not really belong to a journal.
Mm-hmm.
So what we need is maybe kind of a different figure, like something like a website that includes interviews, that include translations, that includes I don't know, like Q&As in different languages that someone could translate, that where you could make a profile and share who you are. I'm trying to think about that, because I think there is a need to kind of come up with a different way of facilitating exchanges between contexts, between geographies, and between traditions. We need to think what are the main ways. I think that is kind of a short and also long term, because I don't think it's going to be an easy thing to do. But I think in the long term, I mean, one of the things that for me are kind of problematic about, because I've been part of this discussion on decolonizing global health, and I think it's an important discussion. But at the same time, I do feel that sometimes it presents the challenge in a way that is kind of infinite. It can always be further decolonized. So I think it's important to set some standards to kind of figure out an image of what we want, and then try to reach that image, because otherwise it's like a permanently moving horizon, and that can be, in a way, I don't know, it can be very I don't know how to say it. It could induce a certain cynicism sometimes, like it doesn't matter at the end, because it would always be impossible, something like that. And it also means that we need to recognize achievements when they occur. I think that's also important. So it's kind of a very abstract answer, but that's what I think.
Yeah, and I think I resonate with what you're saying. In some ways, I think you're right. There's no end, and so it could be paralyzing to some extent if you think about the vastness of the work that's ahead of us in terms of what it means to decolonize global health. So some practical, I guess, like goalposts can help, perhaps motivate people in the path towards this. So I can see some questions popping up in our Q&A box. And so I will start asking them. The first question is, how can we better prepare students when they're going to another country for studies or academic work? How can we as an institution be better prepared when international students come here?
Yeah, so I think that a good way of doing that is for academic institutions to have kind of a predefined set of collaborations with countries, so that students can already have kind of a deeper engagement. For example, the students should know which countries are the ones that are kind of available when they enter a specific program, because the program has already made arrangements, and there is already kind of an ongoing collaboration. And I think it's important to frame that in terms of collaboration, and to work in terms of collaboration, not just like in terms of potential destinations, but potential like existing collaboration, so that the exchange is more reciprocal.
Thank you. The next question is, oh, well, it's more of a comment, but just that they appreciated your suggestion around communication. And it sounds like a global health social network with translation built in, and translation could be funded. And some of the platforms that we already have could be adapted. So an agreement with your thoughts regarding improved communication and the tools that need to be built in for that to happen.
And can I add something to that? Because I think it's interesting. And I think that in a way, something that people that come from countries with other languages, kind of an advantage that we have is that we know since we are very little that we will need to learn another language, and we kind of deal with the fact that lots of interesting things about life are actually happening in another language, you know. So we, for example, my son was raised in the UK, and he struggles with subtitles. You know, if he has to read subtitles, then for him it's like he doesn't want to, because he's used that everything will be in English in a way. While in my case, I'm so used to subtitles and I can deal with them very happily. You know, it's like we have a different relationship with languages. And I think that's something that could be kind of introduced in education as well. It's like a certain respect of the existence of other languages, and the fact that you will have to struggle a little bit, and you should accept that. You know? Just a side comment on that.
Yeah. So there's also a question: in decolonizing global health, how do we take into account inequities such as race, caste, wealth, education that may be present within a country? Even within a country, you can often find Western educated folks of higher social status leading the discussion, and the marginalized still struggle to find a voice.
Yeah, well, necessarily the answer is kind of a graduality. I mean, you move from one stage where you had no representation from ethnic minorities to one in which you do have. And of course, in this new stage, you will have a new exclusion that you will need to deal, you know, and this is a path. So we need to look at it as a path. Otherwise, we can enter into this paralysis that we were just talking about. Of course, there's voices that, of course, when I talk, like when I talk, someone is not talking, you know, like someone wasn't invited. And that is a fact, and that will happen every time someone is raising its voice. But at the same time, when I talk, I'm kind of opening a door. You know, I'm kind of providing an example. I can be actually kind of empowering someone without even knowing. And I think that's kind of, you deal with the fact that your inclusion is at the same time the exclusion of someone else. You need to deal with that in a dialectical way, as a process.
There's also a question about how can we practice accountability in terms of imposing a sense of saviorism when we visit foreign countries?
I think that global health schools and global health training, they need to, there's a lot of work to do around saviorism, you know, because I think that to a certain extent, the idea that you can be of help and the idea that you can actually make a difference in other contexts it's very powerful. It's a powerful driver. I was reading one of the documents that you included in the invitation, and the fact that many global health students move to a more primary health and family health instead of following a specialization. I think it's a powerful indicator of how strong the experience can be, you know, because you are making kind of a lifelong decision. So I think that this idea, this impetus of you being able to help, it's important, and it should be valued. But at the same time, it needs to be kind of a contextualized. It needs to be made more reflective. Like, because even if you want to help, for your help to be accepted and to be kind of a consequential, you will need to understand the other side and how things happen there, how things work in the other side. It's not just, I mean, it cannot be that you are kind of the owner of a certain technical knowledge and you are simply kind of moving that knowledge and that technical ability to a context where it doesn't exist, or where it's very scarce, you know, that cannot be the only story in a sense.
Mm-hmm. Okay, and then we have a question here. How are the efforts that you described to even the field counterbalanced by the brain drain and the assimilation of some of those academic immigrants to the so-called North perpetuate the imbalance?
Yeah, there is a recent piece by Malukai Par around, it's called Double Agents. I think it's on Forbes, where he kind of deals with this through talking with many other people that is kind of in that position, I would say. I think that we all have kind of an individual answer to this in a way. In my case, I think that, I think that you need to be always connected with the needs and the realities of your context, in a way, of the place that you come from. And ideally, you always need to be producing benefits and producing opportunities for the people that stayed in those contexts. I've been moving around a lot, but I always come back to Chile, you know, and I'm always aware of what's going on there. And I always have one or two projects that are directly related to that context. So I think that, but in my case, I'm a sociologist and I do healthcare research. In the case of a healthcare professional, it might be different. In the case of someone that is kind of migrating from one place to the other to work in a health system, I think it might be different. So, but I think it's an important question. It's something to think about.
Mm-hmm. And then we have a question specifically on students. What advice would you give for students interested in getting more involved with global health? What do you think is a good starting point?
I think that at this point, a good starting point is actually, it's not the only starting point, but I think it's important to be aware of the discussion around decolonizing global health, because this has been a very open discussion. I think it's been powerful, because when someone writes about decolonizing global health, other people get motivated, and you can see this. Like at the beginning, it was mostly researchers and scholars in Africa, kind of contesting certain aspects of the field, and then this created a certain interest, and then you see people from Latin America, you see people from Southeast Asia, you see people from, I don't know, Indonesia, and then you see people from China, and you see kind of a whole diversity of voices. So I think that this is a very kind of a straightforward way to being exposed to what the sensitivities are in different parts of the world regarding global health. So you can start from there, and I think you could have a very clear idea of in a way, what is annoying people in Africa around the way global health is implemented there, for example. What is kind of not acceptable anymore? What are the languages that we should avoid? Those things, all of those things have been discussed in these editorials, in these works. And maybe what we need is kind of a compilation of the best around this, because right now we have so many, but that would be, I think, something very valuable for people that is entering the field and entering the discussion.
And just as an add-on, the article that you mentioned by Dr. Pai has been posted in the chat, and we will also be including some resources that you recommended that we share in the chat box at the end of this as well. So something for our audience to look out for in the chat box.
Perfect.
It looks like we've answered all the questions in the Q&A. I'm just checking the chat real quick to make sure that we haven't missed anything in there. But I think most of those questions were moved over to the Q&A tab as well. Oh yes, and this is being recorded and it will be shared. I don't know the exact timing of it, but we will definitely be sharing the recording to the public as well. So in this, the wrap-up time that we have together, Christian, I guess if you're thinking about the future of global health education, what are you hopeful for, or what looking forward gives you hope in this realm?
I think that I think that we have started a process that won't stop anymore. Like, and questions around colonialism, questions around imperialism, questions about asymmetries will stay there, you know, and they won't be easily dismissed anymore. It's like we have set kind of a new standard, you know, for the conversation, and not only for the conversation, also for the interventions and the way we think about global health. And that makes me hopeful in a way, because I think this is a process that will evolve. It's a process that will increasingly include more voices and more perspectives. And we need to set up the mechanisms to include those voices, to be able to give them space, and to see how they shape the field into the right direction, I would think. I think that as a humanity, we face like some incredible challenges, and it's easy to be depressed about that, especially at this point, and especially after so many hours in front of our computers. You know, we are already kind of in a low mood, sort of shared low mood, I would say. But I know that we will rebound from this, but we will need to rethink a lot of things, and I think that global health is probably one of those things, you know, that we need to kind of rebuild from its foundations. COVID itself is a massive lesson in global health inequalities, in global health asymmetries, in terms of vaccinations, in terms of knowledge, in terms of patents, in terms of how the capitalist system kind of pushes into very a path that is dangerous to human life even. So we have kind of so deep challenges. So we have a lot of material to work with over the coming years. So I'm hopeful and I'm excited about that.
Thank you. And I guess, is there anything else that you'd like to summarize or say in the last moments that we have together?
Sure. I mean, yeah, I don't know. I usually share my own experience, and I hope that makes sense. And my own experience is basically the experience of being a migrant, first and foremost. Like, that's kind of the foundation of my thinking. Being a migrant, of course, has some difficult moments. You know, it's not an easy thing, but it is a process of learning from the places that you are, learning from the people that surrounds you, and being able to be a bit lost for a while, you know, and not being afraid of being lost, because in that moment of being lost is where you learn how to kind of rebuild yourself in a different place. And I think that this is an important component of a good global health education. You know, you won't have everything lined up for you. You know, you will be lost, and you should be open to what you can learn in those moments of being lost. You know, don't just embrace your training. Be open to kind of even question your own training when you are in a new context, when you are facing somebody different. I think that would be my wrap-up message.
Thank you. And as the comments have said, how beautifully put. Thank you so much again for having this conversation with me and with our audience today. It's really been a pleasure to be able to talk with you, to think through some of these complex issues together. And I hope that we connect again moving forward.
Absolutely. Yeah, I hope so too.
And thank you to our audience for actively participating in the conversation as well. Again, this recording will be shared publicly as well. So,
okay.
Thank you all.
All right. Thanks. Bye.